This is recorded lecture 6, respiratory system, part 2. We left off last time with talking about adjustments to the metabolic needs in the body. We talked about transport of oxygen by way of hemoglobin. We talked a little bit about the hemoglobin oxygenation dissociation curve. Okay, adjustments to metabolic needs. Temperature. Active tissue is usually warmer than less active tissue. It encourages the unloading of O2, and this shifts the curve, the hemoglobin oxygen dissociation curve, to the right. So what that says, that at a lower partial pressure, more oxygen will be unloaded at a higher temperature, which makes sense. If the tissue is at a higher temperature, that means it is working. An example would be a muscle tissue. That means it's working, and it would need more oxygen. So you would want to unload oxygen at a lower partial pressure of oxygen. So the curve, this is the hemoglobin oxygen dissociation curve, and this is normal body temperature, 37, 38 degrees Celsius. 37 is usually listed as normal, okay? And the reason you need to know that is because if you read any of the medical literature outside of this country, it'll always be listed in the metric system. This is a temperature of 43 degrees, and you can see the curve is dramatically shifted in the direction of the right, so that at a lower PO2, the saturation of the hemoglobin is less. Bohr effect, okay? Active tissue generates CO2. If you have an increase in CO2, we saw the bicarbonate equation previously, CO2 plus water gives rise to carbonic acid, which gives rise to hydrogen ion concentration and the bicarbonate ion, okay? So if you have an increase in CO2, you have an increase in hydrogen ion concentration. If you have an increase in hydrogen ion concentration, by definition, pH is the negative log of the hydrogen ion concentration. So an increase in hydrogen ion concentration would result in a lower pH. So lower pH is going to shift this hemoglobin oxygen dissociation curve to the right, so that at 20 millimeters of mercury, the saturation of hemoglobin is 20%. So at a PO2 of 40, the saturation is at 60%, okay? And so normally at a PO2 of 30, okay, or PO2 of 40, the saturation would be up for this. At a lower PO2 and a higher pH, the saturation would be close to 90%, but you can see now down here that the saturation has approached a little bit more than 60%. So that means that more oxygen is unloading, and with more oxygen loading, that allows some of the CO2 to be transported by way of the hemoglobin molecule, okay? This is this is 3-BPG. It's a byproduct of glycolysis, okay? And 2,3-bis phosphoglyceraldehyde decreases affinity for O2. This is a byproduct of glycolysis, takes place of O2, causing remaining O2 to bind less tightly. Increase of this particular compound, okay, leads to decreased O2 affinity. And CO2 transport, we talk about oxygen transport. Very little oxygen transport is in the plasma. The majority of oxygen transport is attached to hemoglobin. Very little oxygen transport is in the plasma. The majority of oxygen transport is attached to the hemoglobin molecule, and each hemoglobin molecule can have 4 molecules of oxygen attached to it, and a red blood cell has millions of hemoglobin molecules. CO2 is dissolved in the plasma more, but still minor, 7 to 10%. Bound to hemoglobin, 13 to 15%. So we have 7 to 10% dissolved in the plasma. Remember, CO2 has a greater solubility in liquids than O2 does, okay? We also have some bound to hemoglobin in the red blood cells, 13 to 15%. it binds to the globin, but not to the heme. It forms carboxyhemoglobin, okay? So the hemoglobin binds with the CO2, and this is carboxyhemoglobin. 13 to 15% of carbon dioxide is transported in the plasma bound to the globin, not to the heme, not to the iron molecule, but to the globin itself. And it does that by way of this, okay? Then finally, the big majority, 75%, okay, 75% is transported by way of the bicarbonate ion, okay? So this is how it is transported. Some is transported by the plasma, some is transported by way of carboxyhemoglobin, and some is transported in the plasma. This is our equation. This is an equation you're going to need to know. We're going to use it multiple times. This is CO2 plus water yields carbonic acid. Carbonic acid then dissociates into the hydrogen ion and the bicarbonate ion. 70 to 75% of the CO2 is transported in the plasma by way of the bicarbonate ion. So if we have an increase in CO2 for whatever reason, okay, increased activity, increased metabolic activity in the tissue, in active tissue, it is going to switch this, it is going to move this equation, push this equation to the right, push this chemical equation, and the equilibrium is going to be pushed to the right, okay? And so it is going to form the bicarbonate ion. So increase of CO2, we have increased reactants. The system wants to stabilize itself based on an equilibrium constant that you don't need to know, but it wants to stabilize itself. So in order to do that, it's got to form more product. Okay, this reaction occurs both in the plasma and the red blood cells. Carbonic anhydrase, which is an enzyme in red blood cells, speeds this particular reaction. So it speeds that reaction of taking the reactants of carbon dioxide and water and ending up with the hydrogen ion, the bicarbonate ion. So CO2 is transported in blood as the bicarbonate ion. So CO2 is transported in blood by the bicarbonate ion. Just we're not going to look at these diagrams as much as we're going to just take the basic principles, okay? Once it forms the bicarbonate ion, okay, so what happens is there's carbonic anhydrase in the red blood cell. The carbonic anhydrase is going to catalyze this reaction. So CO2 plus water goes to carbonic acid, goes to the hydrogen ion and the bicarbonate ion. There's an enzyme in the red blood cell that is going to catalyze this ion. However, the bicarbonate ion, the most of it is transported in the plasma. So it is actually going to diffuse out of the red blood cell. But because it is a negative ion, okay, the bicarbonate ion has a negative charge on it, and because we need to maintain electroneutrality, positive charges, negative charges, chloride, the chloride ion, okay, which has a -1, is going to diffuse in to maintain electroneutrality. So carbon dioxide and water is going to go into the red blood cells. It's going to be catalyzed by carbonic anhydrase to form carbonic acid, then to form the hydrogen ion and the bicarbonate ion. Hydrogen ion is H+, bicarbonate ion is HCO3, okay? The bicarbonate ion is going to diffuse out into the plasma where it's going to be transported. Remember, 70 to 75% of the bicarbonate ion is transported in the plasma. Well, in order to maintain electroneutrality, chloride is going to diffuse into the red blood cell to maintain that electroneutrality, okay? In the pulmonary capillaries, this is going to be reversed, okay? It's going to be reversed because in the pulmonary capillaries, we're going to need to offload, okay? We're going to need to offload the bicarbonate ion into the pulmonary capillaries so we then can give it into the alveolus, okay? So in the pulmonary capillaries that are surrounding the alveoli, okay, in the pulmonary capillaries that are surrounding the alveoli, we're going to have the reaction in the reverse direction, reaction in the reverse direction. We're going to have the chloride ion going back out of the red blood cell, the bicarbonate ion coming back in here. Carbonic anhydrase catalyzes the reaction in the reverse direction. It's going to form CO2 and water. And so we had CO2 transported by way of the red blood cell is carboxyhemoglobin. We had CO2 transported in the plasma as just CO2, and we had CO2 transported by way of plasma as the bicarbonate ion. So all that is going to shift in the opposite direction so that we can unload a bunch of the CO2 into the alveolus and blow it off, okay? And so these are just schematics. What's the Haldane effect? With lower levels of oxyhemoglobin allow for higher CO2 carrying. So lower levels of oxyhemoglobin allow for higher CO2 carrying capacity of blood. So if the blood is not saturated, then this allows for more CO2 to be carried by way of the blood. The oxyhemoglobin can bind with CO2. The oxyhemoglobin buffers more of the hydrogen ion. The oxyhemoglobin buffers more of the hydrogen ion. So the oxyhemoglobin, this is hemoglobin without oxygen, can bind CO2. The oxyhemoglobin, remember when we have the reaction when CO2 combines with water and then forms carbonic acid, then forms a hydrogen ion and a carboxyl and the bicarbonate ion, the oxyhemoglobin is going to be able to buffer some of this hydrogen ion, and we're not going to need as much chloride there. Homeostatic imbalances, if we have pneumonia, then the membrane is thickened, okay? If the membrane's thickened, we're not going to be able to exchange gases, okay? Emphysema, we have breakdown of the alveolar walls that decrease the surface area for gas exchange, okay? So here's normal alveoli and here is abnormal alveoli with breakdown of the alveolar walls. The alveolar walls, the alveolus is where gas exchange occurs. If there's walls are broken down, then we're not going to have as much gas exchange occurred. You can still ventilate, you can still do mechanical ventilation, you can bring gas into the lungs, into the level of alveoli, but it doesn't perform maximally because that huge surface area of the alveoli where the gas exchange is going to occur, the gas exchange does not occur because these walls are broken down due to emphysema. So this is another reason. This is one of the first signs. Emphysema is one of the first signs you see in young smokers, okay? They don't get COPD, that's later on. They will get emphysema, so they'll start breaking down the alveolar walls. A number of models, okay, a number of the female models smoke in order to avoid eating. And in those young models, 18, 19, 20 years old, you can see emphysematous changes because of smoking. So if you're a smoker, just remember that if you've been smoking for very long, you're probably already starting to break down these alveolar walls, okay? And this is an emphysematous lung, okay? Neural control of respiration, there's a number of centers that are controlled for respiration. We have a center in the medullary area, okay, a rhythmicity area, okay. We have a ventral respiratory group. In the medulla pacemaker, the autonomic nervous system controls the inspiratory muscles. Remember, exhalation, normal exhalation, not a maximum exhalation, but just a normal exhalation is passive. So all we need to do is to send a signal to inspire and have not a signal to expire, okay? So if we have a signal to inspire and we don't have a signal, that means we're going to automatically expire, because during inspiration, we contract muscles. During normal inspiration, we contract the diaphragm, okay? The diaphragm is going to, this is the diaphragm that sits in the junction between the thoracic and the abdominal cavity. When we contract this, this is going to drop down, and we contract the external intercostals. So that's during inspiration. Well, if we no longer have a signal to contract, then these muscles are going to relax. When these muscles relax, then they will decrease the area of the thoracic cage. Okay. Remember, when they contract, the external intercostals raise the thoracic cage upward and outward, and the diaphragm contracted it downwards to increase the volume of the intrathoracic cavity. When we increase the volume, we lowered the pressure below atmospheric pressure, which at sea level is 760 millimeters of mercury. And when we did that, air, which is 760 millimeters of mercury outside of the lungs, just automatically came in. So you can pretty much guarantee on one of your short answer questions, you're going to have to go through how we breathe. So you're going to have to be able to tell me about Boyle's law, tell me which muscles we're just going to talk about normal inspiration, which muscles participate, what happens, why air goes in, why air goes out. So if you're not, it's not a complicated thing. It's purely a mechanical thing. You increase the space, pressure goes down. If the pressure outside is greater than the pressure inside, air is going to flow in. That's diffusion, okay? Then when the muscles relax, when the diaphragm relaxes and goes back upwards, and the external intercostals relax, and the rib cage and the thoracic cage settles back downward and inward, then the volume inside the thoracic cage is increased. Remember, during inspiration, we reached a point where pressure inside and pressure outside was 760. Initially, when we had inspired, the pressure was lower than 760, and so air flowed in until it reached 760. Now we decrease the volume, so the pressure inside the thoracic cage is greater than the pressure outside the thoracic cage. So it is some number greater than 760. If it's some number greater than 760 inside, okay, and 760 outside, and you have open channels, okay, air is going to flow from inside to outside. So be prepared on the short answer question to tell how we breathe in a mechanical standpoint using Boyle's law and talking about the muscles associated just with normal tidal volume respiratory breathing. So we have a pacemaker here. Autonomic nervous system controls inspiratory muscles. Exhalation is passive. The phrenic nerve, okay, the phrenic nerve goes to the diaphragm. Phrenic nerve goes to the diaphragm. Intercostal nerve to the external intercostal muscles. These are the two muscle groups responsible for normal inspiration. So the phrenic nerve goes to the diaphragm. The external intercostal nerve goes to the intercostal nerve goes to the external intercostal muscles. Sometimes when somebody has very chronic hiccups, hiccups are an irritation to the diaphragm. Surgery has been proposed to cut the phrenic nerve to that particular side of the diaphragm to see if they can correct the hiccups. These are people who hiccup all the time, get no relief from medication, no relief from anything else. So this was a treatment in the past. Cyclic on and off impulses, approximately 12 to 15 times per minute. It's hard to measure your own respiratory rate. You can measure your pulse rate. You just put your fingers on the radial artery, measure your pulse rate, and the heart's going to keep beating. Okay, you have some conscious control of your heart rate, but you have very little of it. But respiratory rate's hard to measure your own respiratory rate, because as soon as you start counting it, then you're conscious of your respirations. But normally we breathe on average of 12 to 15 times a minute. Eupnea, normal respiratory rate, okay? We had a ventral respiratory group. Now we have a dorsal respiratory group, okay? Integrates input from peripheral stretch and chemoreceptors and communicates to it by way of the ventral respiratory group, okay? We may need to either increase or decrease the respiratory rate, okay? We may need to increase or decrease the respiratory rate. So this is one of the ways that we can do that. We have some Pontine, okay? We have Pontine respiratory centers that fine-tunes the breathing rhythm prevents lung overinflation. You know, we don't want to, one of the problems during anesthesia, if you're not careful, is if you overinflate the lungs, especially if you significantly overinflate the lungs, you could get a pneumothorax. So, and it's also a problem in the emergency room for somebody not experienced after they've intubated a very young patient, maybe a 1-year-old, a 2-year-old, and they're not familiar with how much volume they should be pushing in with the ambu bag. They can cause a pneumothorax because they overinflate the lungs. But this is something to fine tune the respiratory system and to smooth out the transitions from inspiration to expiration, particularly during sleep, exercise, and talking. When we talk, we inspire and expire. We inspire and expire during our normal speech patterns, but we don't think about that, okay? And so we could have a center we could have our ventral respiratory group that is, you know, causing us to want to inspire our medullary control, causing us to want to take a breath 12 to 14 times a minute, but it might not be exactly what we need if we're trying to give a talk. You know, if we're trying to give a talk. So we have this pontine respiratory group, okay, to smooth out this. And when you exercise, when you sleep and talking, this is one of the things that it does. We also have cortical influences. We can voluntarily control breathing, okay? We can take a deep breath if we want to. We can increase our respiratory rate by getting nervous if we decide we're going to increase our respiratory rate. If you get into a panic attack, first thing you do and you check your pulse and it's beating 160, 180 times a minute, then you start getting panicky, even more panicky, and you start breathing fast, okay? And that's voluntary. You're doing that to yourself, okay? And so we can voluntarily control our respiratory rate. However, when we eventually get a buildup of CO2 and the hydrogen ion, that will override our voluntary control. So we only have certain limits, okay? We only have certain limits before this is overridden. We have chemoreceptors located in the medulla and the aortic and carotid bodies, okay? We're going to have, just like when we talk about the regulations of blood pressure, we have regulations of respiration, okay? And just like when we on blood pressure, we had some of those sensory receptors were in the aorta and the carotid bodies. Same thing here, okay? And we also had some receptors in the brain, or in the lower brain area. And so we've got receptors here. We've got chemoreceptors, okay? We've got chemoreceptors trying to pick up chemicals, okay? It's sensitive to the hydrogen ion buildup and to the CO2 buildup. Because if we have CO2 buildup, we're going to push that equation that we looked at. We're going to push that equation that we looked at, and we're going to have a buildup in hydrogen ions, okay? The peripheral nervous system is sensitive to CO2, O2, and to the hydrogen ion concentration. So central nervous system is sensitive to CO2 and hydrogen ion concentration. Peripheral nervous system is sensitive to CO2, O2, and H2, okay? Central nervous system inside, okay, the medulla, okay? Peripheral nervous system would be in the aortic and carotid bodies. Inflation reflex, Herring-Bauer reflex, baroreceptors on the bronchi and bronchioles protect against overinflation by direct inhibition. That says that we consciously cannot overinflate our lungs, okay? Now, obviously, if you're intubated and paralyzed and somebody else is inflating your lungs, that's different. Hypercapnia is an increase in PCO2 levels, okay, greater than 40 millimeters of mercury. This is hypercapnia, so that's increased CO2 levels. You could see increased CO2 levels in somebody who's not ventilating, okay, who's not ventilating. Somebody who is on drugs, okay, and is lethargic, somebody who is on a huge alcoholic binge and was lethargic, or you can see, so that would be the mechanical ventilation, and you can also see if you have a breakdown of the alveolar membrane, okay, where this exchange is not occurring, where O2 exchange and CO2 exchange is not occurring, you can have hypercapnia. Okay, hypocapnia is just the opposite. It decreased PCO2 levels, and so it's less than 40. It's really not this tight of a range. Okay, but this is a a point where you can get a range as to what's hypercapnia and what's hypocapnia. Well, when would somebody suffer from hypercapnia? When they're in a panic attack and hyperventilating. They are blowing off CO2 right and left. So what's the treatment of choice? Number one, try to get them to calm down. And number two, have them to breathe into a paper bag. Okay, they breathe into a paper bag. They're going to re-breathe in some of the CO2 they have been pushing off. Okay, so hypocapnia is decreased CO2, and that could be related. We're just talking about respiration. We're not talking about metabolic. When we get to the kidneys, we'll be talking about metabolic acidosis and alkalosis, but we're talking about increased ventilation, so decrease the PCO2 levels. And swimmers used to hyperventilate, and they still do, but what happens is sometimes they faint, and if they faint underwater, then they may drown. Okay, hypoxia is a deficiency of O2 at the tissue level. Okay, can be from a number of reasons. You could be standing on the summit of Mount Everest and take your oxygen mask off so you can get a big picture smiling at your family. Okay. Hypoxia is inadequate O2 delivery to the tissues. Anemic hypoxia, you don't have enough red blood cells. Okay. Or you have a hemoglobin, okay, that is either abnormal in the content of its amino acid sequence, or it's abnormal in structure, because when you have sickle cell anemia, the cells are going to sickle, the red blood cells are sickle, so they're going to carry much oxygen. Okay, so you can have anemic hypoxia, too few red blood cells, or abnormal hemoglobin. You can have ischemic hypoxia, circulation is impaired. Okay, if you have a blood clot, either a blood clot to a portion of the heart or to a portion of the brain, you can suffer ischemia. Okay, ischemia is lack of blood flow, and if you don't have any blood flow, you're obviously going to you're not going to have any oxygen in that area, and that's going to be very detrimental to those areas. And histotoxic body cells can't use O2. There are certain substances that bind more to the hemoglobin molecule. They have a greater affinity to the hemoglobin molecule than the oxygen molecule. So if you take those substances and they're bound to the hemoglobin molecule, then you're not going to have any oxygen bound to the hemoglobin molecule. You can have carbon monoxide poisoning. Carbon monoxide is binding affinity 200 times greater than O2. Carbon monoxide is colorless, odorless gas. Okay, and mostly you see that in places that have inadequate ventilation. Most of the time, it's places in colder weather where they'll start the car in the garage, and the fumes will go from the car into the house. Okay, or it can be it's not been too terribly long ago, 5 to 10 years ago, there was a couple, or maybe a couple of groups die at one of the hotels in Key West from carbon monoxide poisoning because they had inadequate ventilation, and I don't know where it was coming from, but I do remember hearing about that. Okay, you can have COPD, chronic obstructive pulmonary disorder. You can have, which is an obstructive emphysema, enlargement of the alveoli, followed by obstruction of the alveolar walls. As lungs become less elastic, airways collapse during expiration. Okay, so the airways enlarge. Okay, the alveolar walls they start destructing, and so they're still open. You can still do some exchange, but every time you expire, the the alveolar collapse. So you have a collapse of the airways during expiration. Normally, with normal alveoli, we don't have that because of surfactant. You know, we have surfactant cells in our alveoli, okay, that secrete surfactant. Surfactant decreases the surface tension of water. Water has a high surface tension. Because of the high water surface tension, if we didn't have something to decrease that when we expired, that surface tension, because of its increase, will cause the alveoli to collapse. And the body is equipped with surfactant cells in the alveoli that start secreting surfactant at about 26 weeks in utero. And we talked about respiratory distress syndrome with a premature that was born early and has no surfactant and has to go on ventilation, keep the positive pressure ventilation to keep the alveoli open. But as the lungs become less elastic, airways collapse during expiration. Accessory muscles are increasingly used. So you can see these people, they are really working to breathe. Okay, they're really working to breathe. They're not like you and I. We're using our external intercostals and we're using our diaphragm. Okay, and for us, that allows us to mechanical ventilation and ventilation, internal and external ventilation at the level of the alveolus, at the level of alveolus and the level of the cell. Okay, because they have these abnormalities related to the disease process. Because of the abnormalities related to the disease process, they're not able to exchange the gases. They're not able to exchange the gases at the level of the alveolus. If they're not able to exchange the gases at the level of the alveolus, they're going to have an increased CO2. They're going to have increased hydrogen ion concentration. They're going to have a decreased O2 concentration. Okay, so they have everything kicking in to tell them they need to breathe more. Well, the only way to breathe more is to use your accessory muscles. And we went over the accessory muscles. And so when you meet a patient with COPD, they are really working to breathe, okay? And eventually it becomes so problematic. They become so problematic that they exhaust themselves. Initially, they're able to breathe as long as they're sitting. They may be able to get up and walk from their chair to the couch or from their wheelchair to the bathroom, but eventually even that exhausts them. And later, at some point later on, they just wear out. The respiratory exhaustion, just eventually ends up killing them. Okay, it ends up killing them because they use so much of their energy trying to breathe. Okay, and this is not a disease that gets better. This is not a disease that gets better. If anything, gets worse. Okay, over a period of time. And so there's there are stabilizing treatments that last temporarily, but as the disease progresses, this is not a very good disease. Okay, more energy devoted to breathing, 15 to 20% of the energy devoted to breathing, as opposed to 5%. Huge volumes of air trapped in the lungs, leading to barrel chest. Capillaries and alveoli disintegrate. Okay, physical symptoms. There's two big categories of them. They're pink puffers, normal blood gases, but work so hard they tend to be thin and frail. Okay, so they are able to work hard enough to get their blood gases to a normal range. Okay, but they tend to be thin and frail. And so what will happen is they'll eventually exhaust themselves. Pink because they usually overcome their deficit, and it's usually from emphysema. And then the blue bloaters, that's the one you see a lot. Okay, they're more of a stocky build. They're bluish cyanotic. That means bluish in tint. Okay, they usually have hypertension and right-sided heart failure and chronic bronchitis. And so that's the end of the lecture of lecture 6, the respiratory system, part 2. Thank you.